Transcatheter aortic valve is a rapidly evolving technology. It was approved based on the partner trials cohort A and B in 2011 by the FDA. The reason for the approval was that in partner cohort B, they compared the transcatheter aortic valve in very extreme surgical risk patients who were deemed inoperable and compared transcatheter aortic valve to usual care, which included balloon valvuloplasty, and that showed a mortality reduction, while the partner cohort A, which was an extremely high-risk subgroup of patients who had the option of undergoing both surgical and transcatheter aortic valve, there was comparable mortality at the end of the follow-up period of the study. So that led to approval of the transcatheter aortic valve for patients who were extremely high risk or deemed inoperable in 2011 by the FDA. And so we decided to look at what the outcomes were in the very first year after its approval in the US, where we wanted to look at specifically using the NIS or the National Inpatient Sample Database, outcomes like mortality, mean charges of hospitalization, and median length of stay. So hence we decided to do a study where we could compare not only the transcatheter aortic valve in and of itself, because a lot of other registries are doing that, but the other issue that we did want to do was to compare and contrast this against a contemporary group of patients who underwent surgical aortic valve replacement. So we looked at both unadjusted and multivariable as well as propensity adjusted models to look at outcomes. For the unadjusted models, mortality was actually comparable in the very first year for extremely high risk patients undergoing transcatheter aortic valve compared to possibly a lesser sick population who underwent surgical aortic valve. For the propensity adjusted versus the multivariate adjusted models, there was the differences in mortality remained comparable. For mean charges of hospitalization, for the unadjusted model, transcatheter aortic valve had a little bit higher expense associated or mean charge of hospitalization associated with it compared to surgical aortic valve, and this was statistically significant. However, in the multivariate and the propensity adjusted models, the differences in mean charges of hospitalization went away when you compared for a similarly sick population of patients in the propensity model. Their charges with hospitalization for transcatheter aortic valve and surgical aortic valve replacement were comparable. And that brings us to our third very important finding, which showed that both in the crude as well as adjusted models, the median length of stay for transcatheter aortic valve replacement were 8 days, and compared to 13 days in the propensity adjusted models for surgical aortic valve replacement and 11 days for the crude overall model. The take-home message is that both surgical and transcatheter aortic valve are obviously viable options for a patient who has bad symptoms or is suffering from advanced aortic stenosis. However, with possibility of a percutaneous procedure, median length of hospitalization being lower, which I'm sure many patients would prefer to go home rather than be in the hospital, and as more and more the technology becomes available, there is a possibility, because of the different products being available and for the economics as it evolves, there is a chance when the hospitalization charges go down, transcatheter aortic valve replacement can be a very viable alternative, especially for patients who are extremely high risk or inoperable for a surgery.